And I want to welcome you all to our MDA webinar. And I've titled it, How Can We Increase Production / Collection, Increase Patient Acceptance of Our Treatment Plans and Our Financial Arrangements. And while doing this, how can we decrease the level of stress in our dental offices? It seems like a rather lofty goal, I understand, and I would agree. But hopefully by the end of today, after we start talking about this, you'll see that this is something that can be achieved, and that I'm going to give you some ways to do that. As Shauna said, this is me, and I'd be happy to answer any questions or comments, or positive or negative, and don't hesitate. Shauna said I was a practicing dentist for 40 years, or close to 40 years. Graduated from the University of Detroit when it was the University of Detroit, not University of Detroit Mercy. I had my own private practice in Plymouth, Michigan for that period of time. Eventually, I sold my practice to my associate, who is still doing quite well, actually way better than me when I was there. But the reason that we're talking today, and the reason that I've been asked to present this webinar, is due to my practice consultant. And as Shauna said, for the last 20 years, I've been working in the practice consulting area. While I was practicing, it had become mainly a 60-40 split. I was doing more consulting than I was at the office, and that's what precipitated the practice sale. But started out doing practice transition consulting, helping dentists buy and sell dental practices. But it's kind of morphed into more of the strict consulting side of things in the last few years, helping dentists with very specific issues that they may be facing, helping them put plans in place to improve things, or to grow their practice, or to minimize problems, whatever that might be. And that has been my one of my major focuses over the last few years. So that is in essence why you're listening to me today. So let's start talking about how can we improve our practice. So specifically, how can we improve the case acceptance and the financial arrangement acceptance, and do this at the same time reducing stress in the dental office. And I think this picture illustrates what it's like. I know that we're talking mostly to staff members out there, what it's like in a dental office, but we dentists feel the same thing. I mean, how many times have you been sitting there when you're in the middle of prepping a crown or doing some sort of work, and you know that you have two hygienists waiting for you to give you a check, to get a check for you so that they can dismiss their hygiene patient and get on to the next one. At the same time, you know that you have somebody waiting for you to return a phone call, and also there's a supply representative sitting in your private office. It's just a very busy existence in the dental office, and those of you that have been doing this for any period of time know that situation's not decreasing. The amount of things that we need to deal with on a day-to-day basis are increasing, not decreasing. So we're being pulled in many different directions at the dental office. And what this leads to is stress and frustration, and something that all of you in the dental profession, if you've been here for any length of time, more than really 2 days, you know that it's a predominant factor of what goes on in the dental office today. You know, you got to remember too that what we're doing is something that patients don't typically want to have done. They don't want to hear most of what we have to tell them. Think about what we say to a patient, whether we're the dentist or whether we're a staff member. And whether we're the dentist, we're telling them about issues that they should address. Things are changing a little bit in dentistry today. In the old days, it was much more of a need-based type of a decision that patients would make. In other words, they had pain or a problem, or if you could convince them that they had a potential problem, that's where the focus of case presentation was. These days, there is a lot more need-based or want-based. A lot more want-based as well as need-based. In other words, patients want a better smile. They want whiter teeth. They want a certain appearance. So that has changed a little bit. But still, the vast majority of what we tell them, particularly when we tell them what the cost of what we are proposing is, I mean, these are things they don't want to hear. And if you're a staff member, you got to remember, or you got to realize too, and I'm sure you'll agree, almost everything you tell them is stuff they don't want to hear. You start to tell them things about how much this is going to cost, how they have to pay for it, what has to be done before their appointment is made, what their insurance will cover, what their insurance will not cover, what times available you have for appointments. No, you don't have a 7 o'clock on Tuesday evening appointment available. Or no, we don't have Saturday appointments. most of what we have to communicate to a patient is not really what they want to hear. And what this leads to is a tremendous sense of stress and frustration. And that's something that in the last few years, particularly in the last 5 to 10, I've noticed that the stress levels and frustration levels inside of dental offices are increasing. I don't want to say exponentially, but they're increasing substantially. There is a lot more stress and frustration going along with doing the normal work that needs to be done in a dental office. And I have theories on that, and I think they're actually accurate. But basically, what it comes down to, the way that dentistry is trending these days is we need to see more and more patients do more and more dentistry in the same amount of time as we always did, and yet still provide an exceptional experience for the patients, exceptional patient care and patients service. And this leads to frustration. It's like, how can we get more and more people, more and more things, and shove them through a smaller and smaller funnel and still come out with a good result? And I think you see that in the stress and frustration levels that are increasing in practices. So I'm often asked, what's the answer? What is the magic elixir? What's the pill we can all take to lower stress in the dental office and improve our practices at the same time? And I will tell you, maybe unlike what you were expecting, there are some magic formulas. There are some things that do work, and they work fantastically, but they're not tied to what you may normally think. They're not about a specific plan or a specific policy or instituting a new set of evaluation criteria. That's not what really is going to drive change, and particularly drive change at the same time, reduce stress. What's going to do that is that, or what we have to understand if we're going to do that is that knowing what to do, knowing what you need to do, in other words, the specifics of a plan. So in other words, I can give you 14 different plans on how to increase your case acceptance and your financial arrangement acceptance. But that's only half the answer. And I would tell you it's maybe not even half the answer. In my world, we know the techniques. Our dental consultants know what practices need to do. And quite honestly, what I found is most practices kind of know what to do. It's the other half of this, or the other 3/4 of it, that really sets the stage for how effective you're going to be. And that is the two combined factors of belief and buy-in. Belief in your process and buy-in by your dental team. And hopefully all you listening won't be disappointed that we're not going to give you a laundry list of, again, 14 different ways to do these things to improve case acceptance and financial arrangement acceptance. Because it's been my experience, it's been proven time and time again, that unless you have these two basic building blocks, belief in your process and buy-in by your team, whatever you institute in the way of change is not going to work. That can be a little bit esoteric and sometimes a little bit nebulous when I say that. And I'm going to point this out. We're going to talk a lot more in depth about this. And maybe you surmised this based on my psychological background, but it didn't actually occur that way. And I want to tell you about what kind of got me to sort of at least start thinking about this. And then it was proven to me time and time again. I went to a seminar many, many years ago. And the seminar, the person giving the seminar was a dentist out of Colorado. And he had, before the institute, for our current DSOs and multiple practice ownership, and he was kind of a pioneer in that field. But he owned 4 separate practices. And he had, I believe, 10 or 12 dentists working in there. At that point, he had stopped working. But he had 10 or 12 associates in his practice. And something that he said struck me as very interesting at the time, and like I said, is a proof of this point. Out of those 12 dentists, they were all around the Denver area. And from periods of time, for different circumstances, the dentist who was sort of a junior dentist was then promoted to a senior dentist in another practice. For whatever reason, the dentists had to switch practices. And what he said is he noticed, and he found it very troubling, I find it very interesting, was that the dentists tended to be who they were, who they are, depending upon, independent of where they were and what practice they were in. So, in other words, he talked about it in financial terms. He said that if a dentist was producing $50,000 a month in practice A, and then he was suddenly transferred to practice B, who was that practice was producing $25,000 a month. He found that over the course of actually a very few months, practice B started to become a $50,000 practice where they had been a $25,000 practice before, and the only difference was the change in doctors. So as he looked at this, he tried to research this a little bit, and he said that a lot of times, whatever happened, the dentist, the $25,000 a month doctor that was transferred to the original practice or another practice, that practice tended to become a $25,000 a month practice. In essence, it may be confusing in my telling of the story, but in essence, a dentist who believes they're a $50,000 a month dentist will make a practice into a $50,000 a month practice. And a dentist who believes they are a $25,000 a month practice will make it whatever the practice is into a $25,000 a month practice. Again, it may seem a little nebulous, but I have seen this played up time after time after time, where I go into practices with 1,000 patients, and sometimes a practice with 1,000 patients has a fantastic recall system. All 1,000 are being seen, twice a year, and some of them are on periodic maintenance visits. And the dentist is very complete in their treatment planning. They do some ortho and they do all their own endo. And that practice may have 1,000 patients, and they're doing $1 million a year. I've seen practices that have 1,000 patients where the recall is not so great. The dentist is kind of getting a little worn out. I can say that because I'm an older dentist. It happens to us all. It certainly happened to me. You get a little, lax maybe, and you say, geez, Mrs. Smith needs a crown. The last time I did one on her, just about bit my fingers off. So you say, you know what, I'm going to watch that too. I've seen that same practice with 1,000 patients do $500,000 a year. So it really is dependent upon the belief in your process when it comes to changing. We're going to talk about that primarily today in you changing a practice, and the buy-in by your team. And in this case, I'm talking about everybody, dentist and team included. So let's start talking a little more about this. And I'm going to explain to you how I saw this just recently. I told you it's been confirmed to me time and time again, but just recently, an example hits very, very close to home. This is the practice I own in Burton. I'm partial owner of Burton. And through a series of events, we combined 3 separate practices into one practice. There were tragic events, dentists being sick, getting sick, passing away in one case, and retiring in another. And we combined these practices together. And the practice, my partner is roughly my age. I went to dental school with him. And he had a very solid practice, but through this series of events, we became a pretty large practice. The numbers are not important, and I don't want to necessarily, talk specifically about the numbers because, $1 million to somebody may sound like a lot, $5 million to another may not sound like much. So it's not important, and it's not a reflection on what's good or what's bad. But in this practice, we ended up with about 3,400 patients on recall. And by my calculations, that means we should have had 15 days of hygiene. I will tell you, and those of you who were with us last week know that in my practice consulting vein, a full-time hygienist should be able to take care of about 1,000 patients on recall. So trust my math here. We should have had 15 days of hygiene. When I talked to the staff about this, after we'd had all 3 practices for about 3 or 4 months, they said, geez, that may be true, but we can only fill 9 days of hygiene. So I call this we need 15 days of hygiene each week, but we can only fill 9 days saga. And as we started exploring this, I started asking a bunch of questions, and I was told that we tried to add days, but we couldn't fill them. We just couldn't take care of this. And what I was able to find out, and I used a similar example last week for those of you that were with me, was that my hygiene team, which was really a team, there were 3 different people scheduling hygiene. There was no really responsibility there, but they absolutely were terrified of having openings in the schedule. Largely due to my partner, who, when he was smaller, had a problem. When somebody didn't show up or no showed, he was very concerned about it. So to not have to incur his wrath, I think that's probably way too strong of a word, but to not incur his wrath, were keeping a huge, long, quick fill list of people they could fill, and we were great. I mean, people would cancel, and an hour later we'd have them filled, their schedule back filled in. So what I did and what I focused on was kind of changing the belief process. In other words, that they had to believe that we did have 15 days of hygiene, and they had to buy in the sense that I had to get my partner to agree that he wasn't going to say a word. In addition, what we did is we changed things around and got a one-person hygiene coordinator whose job it was to fill the hygiene schedule, or predominantly her job. About 75% of her job was being this hygiene coordinator. And I spent a lot of time with her, helping to get her to believe that we could fill this time, and giving her the techniques of how we could do it. And then we got buy-in from her specifically, and then eventually, once the other staff saw it, we got buy-in of everybody. So we were able to change the belief in the buy-in. We got to 14 hygiene days a week. I still think we should be at 15. But in any ways, we're at 14, and we did real well. But that's an example of how belief in buy-in can hold you back, or can help you to achieve the things you want. And I think I just said it, but you got to understand the belief in buy-in goes both ways. Belief and buy-in are very powerful, but they work in both directions. They can work for you and against you. If you've heard the expression, I'm sure many of you have, that whether you believe in something, or you really believe you can do something, or you believe you can't do something, you're right. And that's true. Again, a very nebulous concept, but that is the number one reason in my consulting, when we get to the point where we're instituting new plans or methods or procedures or systems, the number one reasons don't work. The number one reason they don't work is that I don't get belief in buy-in. It's so important now that I won't even recommend a lot of things until I believe I've got belief for buy-in. It's absolutely critical. And an important point here, and I've learned this the hard way as well, belief and buy-in have to precede change. You can't say, let's try this, then you'll see the results. You got to get some of that belief and buy-in before you start, because without that, you're not going to get the change. So let's get to the heart of what all resistance to change is. What is the major reason that people resist change? And what we're talking about here, whether it's staff, practice improvement, increasing case acceptance, financial arrangement acceptance, whatever type of change we're talking about, what's the major barrier to that, achieving that change, is fear. And there's many different types of fear. I think in the dental office, the major one is fear of rejection. And as a way of pointing this up, I know we have a couple of dentists here, think about this scenario and tell me if this isn't true. You're having a relatively tough day. You had an extraction where you broke a root tip. You did a couple of tough crown preps, and somebody was complaining that their crown was 1/32 of a shade off. And you'd gone in to do a couple of hygiene exams, and the patient had some areas they needed to have treated. You recommended a couple of crowns and some other things, and the patient says, "No, I don't want to do that. I don't want to pay for that." When you go in to the next patient, the next hygiene patient, or the next new patient you see, think about how you're feeling about your treatment planning. I think we'd all like to say that doesn't impact it, but I can tell you it does. And when I talk to dentists and we get down to the heart of things and they're honest, they'll admit it certainly does. And I can tell you the point to play this up is, when you get older and worn out like me, you are just less adamant about your treatment planning. I mean, I have the numbers to back that up. A lot of dentists don't like to admit it, and certainly don't like to admit it to themselves, and I don't blame them. But we become more, I don't want to say timid, but our treatment planning kind of goes by the way of how we're feeling. And it's the same thing with staff. When we have to present a financial part of a treatment plan, financial arrangements, if we don't actually believe that we can get a patient to accept a financial arrangement, or if the amount that we're asking for is too much, we'll tend to back off of that. So that fear of rejection is very, very important. There's other fears too, a fear of loss, a fear of the unknown. I mean, what is this new plan going to do for us? And really fear of fear. I mean, I've talked to a lot of staff members that will say, I'm fine, but I'm afraid of what this is going to be. I'm afraid of being afraid. We're doing, I feel pretty comfortable right now. What if we change things? So let's, now that we've kind of got those preliminaries, the psychological aspects of things out of the way, and I hope, I haven't overemphasized, but I hope I've emphasized enough how the belief in the buy and how important they are. Let's talk about some specific things. Let's talk about what we can do. to kind of improve things. So how can we increase treatment plan acceptance and financial arrangement acceptance? I think we have to understand first and foremost, these two items are inextricably linked. They are not two separate items. They are two parts of the same equation. And when I say that, I want to emphasize you can have patient's acceptance of one, either the treatment plan or a financial arrangement acceptance, but without acceptance of both, the patient is not going to schedule treatment. There's a little spoiler alert, those staff members here who do scheduling. Think about this, and you may already have thought about it, but let me encourage you to look at this. If you don't have firm financial arrangements, in other words, if they leave the operatory and they're pretty convinced of the need for treatment, but then they get to you, which is phase 2 in a lot of offices, and I think it should be phase 2. It should not be the doctor talking money. We're going to talk about that in a minute. But if the patient buys into the treatment and says, okay, I need that, and then you present a financial arrangement and they're not all on board, they may schedule, but your no-show rate and cancellation rate is going to increase substantially. And I will also make the point, just as an aside, if you tie money to that first appointment, in other words, you're going to come in a week from Tuesday and get this crown done, and at that same time, you're going to bring me a check for $500, I will tell you your no-show rate and cancel rate will increase exponentially. So I think that points up the fact that they got to buy that treatment twice. You got to remember that selling, I hesitate to use that word, presenting treatment and the need for treatment is one aspect. It's the financial arrangements, the second part that has to be done if you really want to be successful in getting them to, which the ultimate goal is to get them in your chair to get the treatment done. So let's talk about the barriers to treatment plan and financial arrangement acceptance by our patients. And again, two sides of the same coin, but what are the barriers? What are the things that keep patients from scheduling and completing their treatment? The number one barrier is money. And no matter what they say, no matter what patients do, the number one barrier is money. And the reason is this, is that most dentists are pretty good. If in your office you do the treatment plan presentation, I know in some offices they're letting staff members do that, and that's fine if that works for you. But we're pretty good, whether it's a staff member or most times a dentist, in convincing our patients of the need for the care. Most dentists are real good at that. They are, whether they're drawing pictures on a bracket tray or they're showing, intraoral pictures, or they have some fancy software where they, morph a patient into something else once they receive treatment. They show pictures of a large amalgam restoration that's breaking down. They're pretty good at convincing patients of the need for care. It's when you get to the money phase that part breaks down. And basically what's happening is the patients have to determine if the money they're going to pay is worth the benefits they think they're going to receive. So that's the number one barrier. And really, I have 1 and 2 here, fear, and it's just about as big in font as the money. And it is a factor. I think it's becoming less and less of a factor. Dentistry is much more comfortable today than it ever was before. We have a lot of oral sedation techniques and things that we're using that make it less fearful. But money and fear are like 1A and slightly down the totem pole are 1B. So those are the two major barriers. There is a third barrier that I don't really think any longer is a barrier, but you're going to get it used on you from time to time, and that is time. In other words, I don't have the time to get this done. I can't come in. I can't take Wednesday afternoons off and get this treatment done. Well, largely in dentistry, we've eliminated that. We're having much more convenient patient appointment times. We're doing dentistry quicker. So when you hear number 3, when a patient says, I just don't have the time to get this done, you pretty much can believe it's an excuse for number 1 or number 2, money or fear. But those are the 3 barriers, and I say 2 barriers, to patients accepting our treatment plans and financial arrangement acceptance: money and fear. Those are the 2 hurdles we got to get over in order to get patients to proceed with our care. So if we're trying to increase our case acceptance and our financial arrangement acceptance, step 1 is getting the patient to accept the need for care. This may also include their desire for care, as we talked about. For example, in a cosmetic case, the want, the better smile, whiter teeth, whatever that entails. They may definitely want some care. And that's actually an easier issue for dentists to present. We get a much better response when we tell people about things that they want to have done. Think in terms of, a haircut or a massage. You want those things. That you don't have too much trepidation about going to have those things done. If you're going to get a tooth extracted or your crown prep or your tooth prep for a crown or something like that, there's some barriers there, and we have to get the patient to accept the need or the desire for the care. And as dentists, we're very good at that. And staffs and offices that have staff members doing treatment plan presentation are pretty good at it as well. It's the second step, as I said today. Our focus here today is going to be on getting the patient to agree that the cost of the care is worth the benefits of the care. That is the key. When it comes to talking money, dentists should stick to dentistry. I'm absolutely convinced of this. And not just because I found in my own case it was best. I have found it in just about every other case I've ever been involved with. Dentists are not good at talking money. When we present our treatment plans, it's a very personal thing for us. When somebody rejects our treatment plans, we have a lot of problems with that. So I think the dentist should stick to talking about the care, the need for the care, or the want of the care, what can be done, the mechanics of the care, and leave the financial arrangements to somebody who's better at it. And I think just about anybody's better at it than us dentists. So the second part is getting the patient to agree that the juice is worth the squeeze. As I said, dentists are good at talking treatment sometimes, I think most times, but are terrible when talking to the patient about how to pay for that treatment. Universally. I mean, I'm trying to think back in my career, particularly in the last few years, have I ever met a dentist who's good at it? I will tell you that most offices that are doing really well don't let the dentist talk money. We had a joke in my office that as soon as the patient started asking about money, I would say, look, my front desk person who I love to death, Debbie, I would say, look, Debbie won't let me do this. As a matter of fact, I might get fired if I talk to you about money, so I'm going to turn you over to Debbie. But that's an aside. Financial arrangements should be made by a team member that is good at it. And if you're good at it, you're going to like it. And if you are good at it, you like at it, you're going to be successful at it. So here are some specifics I think about how financial arrangements should happen. Number one, you should get on the same side of the table as the patient. And I mean that figuratively and literally. Eye to eye, knee to knee. In other words, you're on the same side of the process as they are. It's you and the patient versus the cost of the care. Not where we traditionally have allowed ourselves to get in dentistry, which is as a mediator between the patient and the cost of their care, between the patient and the insurance company. We want to be on the same side. We're there to do everything we can possibly do to help them to afford the care that they need or want. That is a very significant area place to get to. If you get to that place, you will find your case acceptance, both from a need of care, want of care, and a financial aspect going up astronomically. When you're doing a financial arrangement, you need to be firm but understanding. Again, we understand that not everybody can afford every type of treatment. That doesn't make them bad. That doesn't mean we don't want them in the practice. That just means that we need to find a way to work this out. You need to adopt the philosophy of we're going to work together. The financial arrangement coordinator, which is, I'm going to use that term, the person presenting the financial arrangements, we're going to work together, you, Mr. Patient, or Mrs. Patient, and me, the financial arrangements coordinator, to find a way to afford the dental care you need or want. And you need to be creative when possible. I'll try to give an example of this as we get going later, but that's important as well. So in my perfect world, this is how it should be. On the right is your financial arrangement coordinator. On the left is the patient. I know it's a little schmaltzy, but I think it illustrates the point that we should get to. And I think by doing this, you have to understand, this is not a stressful situation. This is not a stressful event for either the patient or the financial arrangement coordinator. No judgments made. My job is to help you find a way to get this done. And if you can't get it done, we'll keep working on it to figure out a way. All right. we're going to talk a little more specifics about what I think the policy should be, but understand that this is a subtle change, a subtle difference. You're not trying to sell the patient something, you're trying to help the patient. It goes back to the belief and the buy-in part. If you get to that point where you believe you buy into this, you'll see things increase and do better substantially while decreasing stress. So when you're designing your financial policy, we have to understand that it's got to be something the staff believes in and can get behind. And the way to do that is to involve your staff in the process of designing it. I'm going to give you an example of one that I think you ought to strongly consider using, a financial policy. But you're going to see here, and I'm going to hopefully say this many more times, it doesn't matter so much what you say or even how you say it, although that's important, but it's what the belief of the person saying it is and what the buy-in of the person saying it is. You can say the same thing in different ways. For example, and this is one I actually overheard. It was a few years ago, but it was very interesting. And this was in a practice that had just been sold. And the new buyer came in and he wanted to change the financial policy. In other words, it was something that any of you who have been in dentistry for 20 or 30 years know. We were not always good at getting copays at the time of treatment. We were much better at just sending out an invoice and then patients would pay from that. I don't recommend that. I don't think that's a good idea. I think it creates a lot of problems now, but I'm not here to pontificate on that. But in this case, this buyer had said to his front desk staff, said, look, from now on, I want to get copays up front. And this is week 2, which is obviously not the way to do it. But this is what they did. So I happened to be in the office that day. And I could tell the staff was extremely uncomfortable with this process, that it was new and they didn't really see the benefit of it. But more importantly, they were afraid of what the patients would say. And one of them, the main financial person at the front desk, actually said to me, said, why would I pay for something before it's done, before it's completed? So in other words, Crown was prepped. This buyer dentist wanted to have the copay paid that day. And they had always either you had the patient's copay when the Crown was seated, or in most cases 30 days later once they were handed a statement and walked out. So this dentist wanted to change that. And when I heard this front desk person, again, it wasn't like I was sitting right next to her and she told it to me, but she wasn't trying to hide it either. She said to the patient, and I'll use a fictitious name, Mrs. Smith, the copay for your Crown today is $450. And we expect you to pay that, or she didn't say we, she said, the new doctor expects you to pay that today. And the patient said, we've never done it that way before. What's going on? Why is this happening? And she said, the front desk person said, that's not my decision. I didn't make it. And I really don't believe in it, but this is what the new doctor says it should be. I got to tell you, that's the exact opposite of belief in the process and buy-in of the staff. That was never going to work. We did have a discussion after that occurred. I was able to somewhat help in that, but I had a pretty adamant practice buyer who felt that he was doing right, and he took it on the chin. I mean, he lost a lot of patients over it. But again, this was not meant as an example to tell you what to do or how to do it, but just to point up the fact that if you don't have that belief in the buy-in, and consulting your staff as you're designing your own personal financial policy is very, very important to get that. Your own policy should focus on eliminating the financial barrier to care. It should be focused on, okay, what can we do? What kind of options are we going to have so that we can help the patients afford the care they need or want? That's what your focus should be on your financial policy. You also need to make sure, in my opinion, is get out of being the bank. Many times, again, this is being in the middle. I just consulted with the practice a couple of weeks ago that is thinking about going non-participation with insurance, which is actually going to be a good move for them. I think they're primed to do it. But one of the things I noticed as we started talking about is the financial arrangements were pretty loose. They were letting patients finance care interest-free through the practice. In other words, if they owed $1,200, they might say, okay, you pay us $100 a month for 12 months and your balance is paid. What I can tell you is they became the bank, and that became a problem because you had care that was completed and not paid for. Any of you who are familiar with this will understand that a crown that's completed but not paid for in the patient's mind always didn't quite feel right, trapped food, the shade was off. In other words, they have to come up with excuses of why they haven't paid the balance, particularly if they're behind on payments. So you need to get out of being the bank as you design your financial policy. And again, you got to take the dental office and team out of the middle. In other words, we're not everything we can do to make this something that is between the patient and the credit card company, between the patient and a third-party carrier. Anything that takes us out of the middle is a good move as far as designing your financial policy. I'm going to give you an example of my ideal financial policy. And before we start, I want to make absolutely clear, I'm not saying everybody's got to do this. And this is a lot of you are going to read it. I think it's a relatively harsh policy. But I will tell you that this policy was not totally mine. I pirated this from somebody else many years ago. But I've also instituted it many, many times. And again, it's not the policy, it's not the specifics of this policy that are critical. It's the fact that when you institute this or any policy, if you get the buy-in, the staff agreement, you can make this work. Because the people who are implementing the policy, if they buy in, if they believe in it, that's going to come through to the patient, and you can say it in such a way that it makes sense to the patient. All right, my ideal policy, what I think is you should have three options. The first option, and I call this option number one, that is what I call prepay with 5 to 7% cash discount. Let's just, for argument's sake today, call it 7% cash discount. And you can decide whether you want to, and this includes credit card payments or not. In my world, I'm perfectly happy with taking this on credit card payments as well, because predominantly that's how patients pay today. Not too many people pay by checks. But I will tell you that if you're able to get payment immediately, there's something called the time value of money. $1 today is worth more than $1 tomorrow. It's worth a lot more than $1 90 days from now, and worth a whole lot more than $1 a year from now. So I'm willing to take 90% of my fee today, and rather than get 100% of it over the next 90 days. And what I would tell you is there's a couple of provisos here. When I say to take advantage of this prepaid discount, I'm talking about available on the entire treatment plan. This is a tough concept, very difficult concept for a lot of people to grasp, and it's going to strike a lot of people as very uncomfortable. But when you present a treatment plan, I believe you should do a financial consultation once, the first time, and do it on the total patient balance. If you're non-par, that's the total balance of the treatment plan. If you're participating, it's what the non-insurance portion of the treatment plan is going to be, but the entire balance. So in other words, if the entire patient balance is $1,000, you can offer them a cash discount of 7% on the entire treatment plan. Now that may be 2 appointments, 3 appointments, or 6 appointments, but you do the financial arrangements and get a financial agreement on the entire treatment plan. So in other words, they're paying you today, or before you start, that's key. We'll talk more about that in a minute. Before you start, $930 of the $1,000 treatment plan. Even if that means at the first appointment, you're only doing $300 for the service. You've been prepaid, if you will, and that's why it's a prepay cash discount. All right. Option number 2 is care credit or a third-party payer. And again, this is also only available on the entire treatment plan. One of the biggest problems I see, and it's almost universal, is due to a lack of buy-in, a lack of belief on the part of the person doing financial arrangements. They have a difficult time doing financial arrangements on an entire treatment plan. It's something that I went through in the practice I own as we incorporated practices. And it just pointed up very, very bluntly to me where those problems occur. And the problem in my practice occurred, or in this practice, these practices occurred, was that I didn't get buy-in and belief. And because I didn't, all the things they tried to implement to get this to do complete case treatment planning or financial arrangements were met with varying degrees of success. No matter how I tried to present it, no matter what I tried to incentivize it on, no matter what bonus plans I developed to get it done, it was the person. There was one person that we had mainly responsible for this, and she just wasn't doing a great job. And, got to be honest with you, even today, she's still not doing a great job. And we might improve that where I could get agreement with my partner, but that's a story for another time. But in any event, without that buy-in and belief, that's what the problem occurred. So option number 2, as I said, care credit or third party, complete case treatment planning and complete case financial arrangements. And I often hear, well, geez, the credit card or the care credit charges interest. Yes, they do. But so does your credit card. So if you put this on your credit card, you're going to pay interest too, unless you pay it all off at once. And clearly, if they could pay it all off at once, they would take the 5 to 7% cash discount. And if they can't pay it all off at once, why do you want to extend them credit interest-free or even charging interest, which is a whole other deal? There's all kinds of actually legal things you need to get and permission slips and all kinds of stuff to be able to charge interest. So don't even go there. As I said, my option number 2 is care credit third-party payment. My option number 3 is what I call pay-as-you-go. And this is what traditionally most dental offices are doing right now. You need a crown, your co-pay is $500. How are we going to take care of that $500 at the appointment you get your crown for? A lot of practices are saying, okay, I want $250 today, I want $250 when we cement it. Whatever you use, that would be my third option. And again, as we look at these are the only 3. They may seem kind of harsh. They may seem kind of something that you can't really get behind. And I will tell you, it's not so much what this policy is as much as you develop it. I'm advocating this because I have done this and seen it work a lot of times and actually just really decrease the amount of stress in an office. Think about it. If you have a case that's going to have 6 appointments, does that mean you need to do 6 individual financial arrangements or 6 individual case presentations? You're multiplying the number of work you need to do by 6. And it's a subtle concept, and I'll put it out there. It may take a while it may take additional discussion before you believe it. But what I have found is that it's not, when we have a problem with putting out an entire case treatment plan or entire case financial arrangement, it's not in the patient's mind. In other words, to them, $100 is $1,000 is $3,000. It's all too much. It's not the fact that there's some points along the way in which they just won't accept anything discussion over that amount. That's not true. The barriers are in our own minds. We think $100 or $1,000 or $3,000 is too much. It's not in the patient's mind. All right, but I want to make the point here, and those of you you do this, and you can see this, and I mean, as dentists, we all know, this is an example of the pay-as-you-go. In other words, you pay for each treatment as you go. So not doing full case treatment plans. You can see this patient had several anterior laminates. Looks like they may need a crown or 2, and they have 4 unrestored implants. This is what I see a lot of. A lot of times you may see half the mouth restored and the other half not restored. This is what results in the pay-as-you-go. I used to do a lot of independent medical exams for insurance companies, particularly car accident victims, and I would see this all the time. We'd see, half the mouth restored and 6 wonderful laminates and, no posterior occlusion. And we all know without the posterior occlusion, if this person doesn't get the posterior occlusion restored, it's going to have problems with those laminates. They're going to chip, they're going to fail. There's going to be all kinds of issues. So I put this in to mainly illustrate the point again that we should focus on complete case treatment planning and complete case financial arrangements. So I want to give you an example. I'm gonna tell you now and do one for you. And again, I'm not an expert at this, but I want to show you what this kind of sounds like and what this looks like when you're talking to a patient. And our fictitious patient here, Mrs. Jones, needs 2 crowns, a core, a couple of fillings, and her fees are $2,600. She has a $1,200 maximum on her insurance, so her remaining patient balance is going to be $1,400. So this is what I think the financial consultation should sound like. As always, I told you we're sitting eye to eye, knee to knee. I'm on the same side of the table with her. I've exchanged some pleasantries, not to get off track, because my job is not to ask her how her kids are doing, but my job is to help her. So this is how we would start. I would say, Mrs. Jones, I'm Julie Smith. My job here today is to help you find a way to fit the care you need or the care you want, depending on the situation, into your budget. And I'm going to do everything I can to help you do that. If you have any questions along the way, please don't hesitate to let me know. So let's talk about a couple of the options that we have available to you. The first option, and the one, quite honestly, we primarily like, is that we're able to offer you a 7% cash discount if you can fit the cost of your care into your budget and pay for that before we start. In this case, your total cost of your care is $2,600. Your insurance is going to cover $1,200. That leaves a remaining patient balance, in other words, your balance, of $1,400. Today, we can offer you, or before you start treatment, we can offer you a 7% discount on that balance if you're able to pay that amount entirely in full. In your case, that would amount to $98. $98, that means your cost of your care would be $1,302. Is that something that sounds good to you? Then you would sit and wait for her to respond. Because if she says yes, you don't want to present all three options, because that clearly is our best choice. If Mrs. Jones says, I really can't do that, I don't have those funds available, say, well, that's fine, Mrs. Jones. We do have another option. We are participating with a third-party carrier, a third-party company that will provide insurance. Will provide a loan for you for your care, and that'll be paid entirely up front to us, but you can pay it over the course of time, whether that's a year or 2 years. It's between you and the company, and you can decide. Of course, there is interest charged on that, but if you were to use a credit card, as an example, and we used in option number one, you'd have interest as well. So we can set up an application for you today and take care of that. But one point I want to make before we start is that this is a third party. We're not affiliated with them in any way. So if for any reason at all, they don't grant you this loan, I want to make sure it doesn't affect the relationship between you and us, because we love you. We think you're great, and we want to take care of you. So if by some chance this loan is turned down, we'll find another way for you to take care of the dental care you need. Does that sound like something that fits into what you'd like to do? Again, you wait and see what they say. And if Mrs. Jones says, no, I don't want to do that either, you can say, well, we do have a third option, Mrs. Jones, and this is one, frankly, we don't really like, but it's one that we're willing to do. If this is what it takes to keep you within our practice and keep things going, keep you happy, we'll be willing to do that. And that's what we call pay as you go. In other words, you pay your balance on the service you're having at that particular appointment, and and then remaining balance on the next appointments as you go. Does that sound like something you'd like to do? And again, you wait. Now, if Mrs. Jones says no to all three of those, you got a problem. It means that Mrs. Jones is probably not going to pay. Mrs. Jones is not going to tell you, no, I want you to bill me. She might, but what I'm advocating is you don't want to do that. So this is what I think that financial consultation should look and sound like. I've done some pretty creative things here, and we've worked with people. For example, in this case, let's say we were going to do a pay-as-you-go, and the first one we were going to do one of the crowns, and the patient balance was $500, and the patient said, I can't come up with $500. I have no problem if that practice takes $100 a month for 5 months, gets the $500, and then does the crown. I have no problem with that. But I don't think you ought to do the crown and then bill them $100 a month for 5 months. Again, personal preference, and you can do it any way you want, but in my perfect world, this is what it should sound like. So once you've agreed on financial arrangements, you got to make sure that the arrangements are agreed to in writing and signed by the patient. Absolutely critical. Not so much that you can turn around and sue them. That's not the idea. The idea is that once they sign it, something psychological takes place, and they tend to follow through a lot more on the payment. So you need to have it signed. In today's day and age with tablets and things like this, sometimes it's not actually signed, but there will be some avenue to make sure that it's agreed to and signed by the patient, signed by you. Give the patient a copy of the financial arrangements. Let them take it with it. Let them take that copy with them, so they know what's going on. And the third point here is if the patient is taking advantage of one of the prepay options, make sure it's prepaid before the appointment starts. If you backtrack from one of these options and you allow them to basically become a pay-as-you-go, this is where these things break down. If you allow that to become a pay-as-you-go option, that's what it will be. And you're still going to give them the discount. then it really does cost you money. So keep that in mind. What should you do if the patient doesn't pay as agreed to? If they just, if they clearly, the way I've set this up, that they're basically paying before they get the service done. But the only time this could happen is if you do a pay as you go and you're willing to take the payment after the appointment. I would tend to try and gently get the patient to pay on their way into the appointment. But if by some reason and they slip through the cracks and they don't pay, and then they don't pay as time goes by, but my advice is lose either the patient or the money, but never both. In other words, if you can keep the patient and you want to keep the patient by writing off $50, write off the $50. If it's $500 and you say, I'm going to get that money, we need to have that money, realize that you may lose the patient, but get one or the other, but don't lose both. So my promise to you is if you institute these concepts and methods we talked about today in some shape or form, you'll not only increase patient acceptance of treatment plans and financial arrangements, you're going to lower the day-to-day stress in your office. And again, let me emphasize one last time, it's not specifics. It's not exactly what you do that's important. It's the belief and the buy-in from you and your staff, from the dentists and their staffs, that will determine how successful you are in this process. So once again, here's my contact information. I'd be happy to answer any questions.